Afternoon, and a very warm welcome to this latest edition of the MHR Supported Incubator for AI and Digital Healthcare Incubator webinar series. I'm Jeff Hogg. I'm a clinician scientist based between the University of Birmingham and University Hospitals Birmingham. I'll be chairing us through this afternoon. So, for those of you who are joining us for the first time, welcome. This is a demand-led webinar series that gives us the chance to invite experts on to share work and insights from key areas and create an opportunity to dig into these exciting topics and share some ideas and challenges. And this afternoon particularly bears that in mind. We're looking at a mixed methods evaluation, so we've got a few different speakers and perspectives with Q&A sessions interspersed between, and a good healthy part of the session for discussion at the end. So please do use the Q&A button at the bottom you should find to type any ideas and thoughts in as we go along, and we can dig into them in those corners for Q&A and discussion. And if we do happen to run out of time, please don't worry, because we'll be able to make a note of those questions, partly to direct kind of future talks on the webinar series. We may be able to reach out to you afterwards as well to get some answers for you. The other thing just to flag is that, as per usual, we'll be recording today's session. So if you want to rewatch anything or flag it to any colleagues who weren't able to join us, we'll be sure to share the links for that afterwards. Great. So, moving on to the content of today's session, a few years have passed now since some major national investments in procurement and implementation of diagnostic AI technologies into NHS healthcare pathways. One of these, you may remember, was the AI Diagnostic Fund, which was launched by NHS England back in 2023 and provided £21 million to 12 imaging networks to implement AI for chest diagnostics. Now, these national initiatives, like the AI Diagnostic Fund and others, remain responsible for many of the real-world examples of AI use you can actually observe in the NHS today. But it can be hard to understand if the success of these initiatives extends beyond the simple adoption of the technologies themselves, and also what learnings can be taken to other AI implementation efforts. You may remember that last May on the incubator, we were able to host the NHR-funded Rapid Service Evaluation team working to address some of these questions. So it's a real pleasure now to be able to welcome back three of the team who've concluded the next phase of their work to tell us more about that. So I'll start by handing over, because we've got three speakers today, introducing to Dr. Angus Ramsay, who's Principal Research Fellow at UCL and Deputy Director of NHR Rapid Service Evaluation Team, to kick us off. So thanks very much, Angus. I'll hand over to you and let you share screen and take it away.
Oh, thank you very much for the helpful introduction, Jeff, and we're really delighted to be here. I'm just gonna bring up our slides. Hopefully that works.
Okay. It looks super. Thank you.
Excellent. Lovely. Okay. So yes, really helpful context given by Jeff there. As he said, I'm going to be, myself and my colleagues, Chris Sherlaw-Johnson from the Nuffield Trust and Kevin Herbert from Cambridge University. We're going to be talking through some of the key findings from the second phase of our evaluation, looking at artificial intelligence in chest diagnostics as implemented through the AIDF program. So a bit of general background, depending on how much people know. So it's thought that AI to support chest diagnostics may support faster and more accurate diagnoses, reducing pressure on clinical teams, and hopefully reducing overall resource use and costs. However, there's limited evidence, particularly from the real world, on how AI tools are implemented, how they're experienced, the effect that they have on service delivery, and other outcomes, and their implications for costs and resources. We've already covered the AIDF. What's important to note, I think, in addition, is that the AI tools that were being implemented through the AIDF program were only designed to be used as clinical decision support. Ultimately, decisions were always being made by clinicians. We were commissioned, we're basically funded by NIHR to be a responsive team looking at innovations in any sort of health and care setting. We were commissioned to conduct an independent evaluation of introduction of AI tools to AIDF. Phase one, which we spoke to in May of last year, provided a substantial review of the evidence, indicating some of the gaps that were discussed in the previous slide, but also providing empirical work, offering lessons on some of the processes of procuring AI tools and preparation for deployment of the AI tools, and many of the factors and obstacles to getting through these processes. Phase two, which we've just completed, was focusing on the actual implementation and usage of AI tools, how these were being experienced by different stakeholder groups, including frontline staff and patients, and looking at the impact on service delivery and costs and resources. So this is just an overview of our study design. I won't go into it in depth, but essentially, as Jeff said, this was a mixed methods project. So we used qualitative methods, so interviews and observations and documentary analysis to understand implementation and usage and the experiences of staff, patients, and staff and patients. We used a quantitative set of analyses to look at the impact on service delivery. And we used a health economic approach to understand the implications for costs and resources. We've also been using a range of workshops and so on to bring together some of the learning. Underlying our approach, we have had some great patient and public involvement and engagement right the way through this 2.5-year project. An important focus of our work right the way through the design and the analysis has been considerations around equalities, diversity and inclusion. And the overall analyses that we're going to be conducting are going to be framed by the major system change framework, which looks at different components of complex change and how they interact. In terms of the approach of our study, we conducted quite a lot of work. So we recruited 3 NHS trusts for in-depth work and 7 NHS trusts for lighter touch data collection. We conducted a substantial amount of interviews, so almost over 50 interviews with different stakeholders at national, NHS organisation and patient level. We conducted a number of non-participant observations of meetings and training, and we analysed almost 100 documents related to usage, experiences and impact of the AI tools. For the quantitative analysis, which Chris will be talking about in a minute, we drew on a range of national data sets, including DIDs, HEADS, and a bespoke data set captured by the NHS England programme. We also captured a range of local data from 6 trusts that we engaged with over the course of the project. For the health economic analysis, we drew on the quantitative data mentioned above, as well as a dedicated questionnaire capturing costs and resources implications of implementing AI tools collected from 9 participating sites. So I'm going to move us on to our headline findings, and the basic structure for this is we're going to talk through each work stream in terms of the key findings and then some of the implications for services and national stakeholders. So I'm going to hand over to Chris. Just let me know when you want me to move on to the next slide.
Angus, so it's on board, as Angus was saying, all the sites were using the AI to support interpretation of the X-ray images. And most of the sites we're looking at were also using it to prioritize images the AI was classing as abnormal. So those were classed as abnormal, put to the front of the queue. One of the sites was also using it to identify images where the AI flagged as being high confidence of being normal, which would then be farmed off to a radiologist employed by the AI company and therefore easing the workload of the trust. So in that context, when it was used to prioritize the abnormal images, the AI tools, the interpretations the AI tools producing were matching human judgment sufficiently well, so that those judged by the human readers as having suspected cancer had significantly shorter turnaround times than those they diagnosed as normal or of minor concern. Turnaround time here is defined as the time from the taking of the image to when the patient then receives the final report of the scan. Also, in terms of changes to turnaround times due to deployment, well, you wouldn't expect any changes to average deployment time if all you're doing is changing the order of who gets reported in some. If you're just changing the order in which the scans are being reported. However, we did find that there were some overall reductions, but these seem to be generally, we think, were due to differences in. These were generally due to in many cases sites were putting in extra resource to read scans to mitigate against any of the downsides that might occur to the AI. And we're also finding there's quite a difference in how this was in what was going on in different sites. There's a question about whether when you start using AI to clinical support, with how it affects the decisions that then are being made by the radiographers or the radiologists about following up. So does this then have an extra impact on CT scans, for example, and then have implications for CT capacity? What we were finding was very variable. Out of the 8 sites we looked at, 2 sites were seeing increases in numbers being referred to follow-up, and 3 showing significant decreases. The other 3 didn't show any general change. The reasons for this are difficult to understand, but they could be related to the resources that have been put in. Different sites categorizing cases for follow-up, how they do that, and whether there was consistency over time as to how they did that. And there may be other factors like lung cancer screening, which was coming into play as well, and that basically reduces the risk of patients that are being referred to chest X-rays in general. When you're looking at things like whether there's any particular inequalities, of what we were able to measure, we didn't find any effects on for example, on the ethnicity of patients that are being in the proportions of patients in different ethnicities that are being followed up. One area there's a gap, however, in terms of things like other comorbidities and things that we weren't able to measure. So the amount of information we had to measure inequalities was quite limited. The other question about the impact on from chest X-ray to CT scans, again, this was varied from some sites to another. Some sites showing significant increases, some not so much. Most sites didn't show any change really in this. But this could be, looking at this in more depth within the sites themselves, we found that a lot of this was potentially due to variations in the actual CT capacity that the different trusts have. Some seemed to have adequate capacity to cope with extra follow-ups. Some were having problems with CT capacity in general, and regardless of whether the AI was being implemented or not, this increase to CT scan would probably be happening regardless because of their capacity problems. Okay, can you move on to the next slide, please, Angus? Thank you. Yeah. So generally, then, using the AI tools to prioritize the reporting of abnormal images. We find that it may support faster diagnosis of lung cancer, but through those increased turnaround times, the time gained there, which may be a few hours here and there, may not be is clinically negligible. Any improvements that are likely to happen with diagnosis of lung cancer are likely to come from any contribution that the AI have to follow-up decisions that clinicians make. So is it supporting more diagnosis of more follow-ups for patients who potentially have lung cancers there? Unfortunately, we weren't able to measure that with the data that we had because of the time over the course of the project. As with many healthcare innovations, the impact of AI interventions can vary due to different service models and the influence of local context, which is really crucial as to where trusts are at the point at which they implement the AI, and what other pressures there are on the system and how they're resourcing it and that sort of thing. But now I'll move on to Kevin, who'll say a bit more about the sort of cost effectiveness and resourcing side of things.
Thank you, Chris, and good afternoon, everyone. My role in terms of delivering an economic evaluation, reflecting some of the opening comments from Angus, was an evaluation based on the real world implementation of AI in this context. So it wasn't looking at the cost effectiveness of an individual AI tool or mode of implementation. It was the real world context in terms of the implementation across different sites with different initial performance levels, different implementation models. So it was an aggregate assessment of cost effectiveness in a real world context where you've got a model where you've got implementations of different tools with different modes of implementation. But given the requirements in terms of the supportive aspect of AI and those key underlying consistencies. So with that in mind, we in terms of the data gathering, we obviously through the questionnaire and through work and data from my colleagues across other work streams, obtained as much information as we could in terms of cost and resource use when it came to the implementation. And as may not be particularly surprising, the majority of costs associated with both implementing and then sustaining the AI tools post-implementation ran through project management functions, integration activities with local IT services, and then subsequently monitoring and auditing of performance after implementation was in place. When it came to the scale of the costs in relation to those, there was a large variation which reflects those different implementation approaches. Some of that was slightly complicated by the fact that at the point at which we were gathering data, implementation had already occurred in many sites. And so the questionnaire was actually being applied in retrospect. And to varying degrees, different sites were able to provide us with varying degrees of depth and granularity in terms of the resource use and cost data, having not been primed to collect that data initially. So we were asking for their remembrances or from documentation or evidence that they may have that actually were able to answer those questions for us. So in respect to that, and given the different implementation approaches, there were large variations in costs, reflective of the different service models. The additional resources required to support implementation use. So whether that was in relation to the project management, which may have come from either specialist project managers in certain sites. For others, it was project management from in-house staff who were seconded across to the role, which brought its own challenges in terms of the actual delivery of implementation. So quite a large variation in costs on those basis in terms of the initial implementation. When it came to looking at the evidence as to the impact and how that might play through in terms of the economic evaluation, obviously one of the key talking points around AI is the potential for time staff saving. Um, as kind of maybe expected, given the role that AI was obligated to take in this instance, in terms of that supporting role and retaining the final human review and sign off of results. There was actually little evidence of time saving across the sites that we were engaged with, and those were primarily around the speed at which clinicians were able to go through reports, which seemed to improve slightly in the one or two instances where any improvements were reported. So probably not surprising that, and it's a pattern that is unlikely to alter notably. Obviously, there are conversations already in place in terms of the potential for autonomous AI reporting, whether that's in whole or in part. So whether that's in relation to the cases such as high confidence normals, which were mentioned earlier. So those for which there was a high degree of confidence that those patients had negative results, which could be reported back, which might be a first stage in terms of autonomous reporting. But however that may be looked to be applied in future, obviously from the point we're at the moment, that would require substantial regulatory changes and a robust evidence base in terms of the performance of AI in chest diagnostics in this instance, but also in terms of long-term performance as well. So there's a lot that would need to change to enable that. In terms of the overall cost effectiveness picture, AI use was actually cost effective given the real world situation that we're reviewing compared to usual care. And that was due to a slight reduction in costs. It was nominally more effective, but the scale in terms of the improvement in health gains was so marginal as to be negligible or in essence no difference. There was a consistent positive effect, but the scale of the effect was so small that in reality those health benefits were we would really report as being negligible. But in terms of the context of the cost effectiveness, it was important to kind of report those two aspects. So even on this the basis that we're running AI now, there was a slight improvement in terms of a reduction in costs and certainly no worse in terms of health benefits, but kind of very little change there. If we could have the next slide, Angus. So the key implications around these findings, in terms of site to site, obviously findings were variable, but as an aggregate, the findings in terms of the impact and cost effectiveness suggest there could and would be value in further deployment. However, there's obviously a need for additional evidence in terms of the effectiveness and outcomes required. And that comes from a need for requiring stronger baseline data and use of controls for comparison. The question in terms of the impact on immediate and longer term patient outcomes. So the AIDF itself and the implementation that we were running range typically somewhere between a year to probably just under a year and a half overall. And so implications in terms of staging of diagnosis and mortality from longer term patient outcomes, where you have those potential improvements in system performance, would require that we would need to look over the longer term to develop stronger evidence on that basis. In terms of both from myself and the quantitative side of things, the data infrastructure presented a number of particular challenges in terms of both the infrastructure of the data and the capacity for data collection, the type of data that were collected, the linkage between data from different sources, and obviously information that we'd be able to obtain from staff. They were the key takeaways from the cost effectiveness and resource work stream that I was performing on. One other element could be in terms of the ability, which may be brought up by innovations and technological changes, is the potential to reconfigure or reimagine care pathways, which might enable kind of like improvements in performance or efficiencies in other ways alongside the implementation of the technology itself. Thank you for your time and attention. I shall hand you back to Angus now, I think it is.
Yes, hello. Thanks very much, Chris and Kevin. So we know that we're going through a lot of information here in this talk. So we just thought it might be helpful to take a little bit of a pause and see whether anyone wanted to raise any questions at this point about any aspect of what's been described so far. So anything about the design, anything about the impact analysis by Chris, or the cost and resources analysis described by Kevin. We just put aside a couple of minutes so that people can clarify any issues they might have.
I can see a couple of questions coming in the chat. What I might do, if it's okay, is have a go, Ben Wilson, at unmuting you, if that's all right, which I think I've done, and just see if you can speak to the questions you dropped in there. That's been fantastic.
Hello,
thank you.
is that, am I audible?
Yep, coming through loud and clear, thank you.
Okay, great, thanks. Really interesting to see this work. Yes, I'm afraid I put a couple of suggestions in, so stop me if I'm taking up too much time. On slide 7, the impact, it looked that there was a couple of things that were clearly not impactful, but there was a suggestion that high confidence normal cases could be detected, and I've heard from other people that this is a use case for AI in chest diagnostics. Clearly, as pointed out in the presentation, machine alone decisions for high confidence normal are not in scope. But what level of accuracy would be needed? For example, if you could reduce the ongoing volume of those going for not high confidence normal, those where there's a suspicion or a borderline case. If they're going through to manual read, what level of performance would the machine need to demonstrate on, for example, 20% that it could say, well, pretty confident these don't need immediate attention, before it would become morally, in a sense, there would be a moral obligation for us to consider using a fully automated process just for that fraction of the caseload. In other words, what do we know what the human performance is on high confidence normals and the machine performance on high confidence normals, and know whether we're actually making things better with a machine than we are leaving it to humans?
I can see that Kevin has his hand up, so I'll let him address that. Thank you so much for that insightful question.
Thank you, Angus, and thank you, Ben. Yeah, that question around high confidence normals was certainly one which was interesting to consider and work with. In terms of relative performance, in terms of the AI slotting into the current care pathway, in support of the human readers. I suppose there are kind of like a couple of contextual points. One is that the fact that there were there were marginal changes, if any, in terms of the performance is, I suppose, reassuring from a human point of view, and both from an AI point of view, in that we weren't aware of any issues around drop-off or major discrepancies between the AI and humans. There may have been some cases that the AI flagged that humans for prioritization that may not have been initially picked up by humans, but I think that was more marginal. Correct me if I'm wrong here, Chris or Angus. I think they were more marginal cases rather than there being a substantial proportion of the cases that were being reviewed. I think that there's certainly the question about how good AI has to be to be acceptable to operate in its own right. As we're seeing at the moment, and some of the evidence in literature in certain use cases, whether that's here or elsewhere, AI does seem to be operating in the same area as humans, if not marginally better potentially in some areas. The question then comes that if the evidence suggests that it's no worse, or even that it may be performing better than humans, how good does AI have to be before the case can be made, both in terms of a clinical and a public acceptance area? There was a third point which has just escaped me at the moment. Sorry, you'll have to excuse me. It's just flown from my head. But yeah. So as it goes in terms of our evaluation, I think there were no notable issues in regards to the potential for the high confidence normal cases potentially traveling down that route to reporting via AI to alleviate the load on the human operators and image reviewers. Hopefully that helps with some of your question, Ben.
Thanks very much.
If I could add something briefly, I mean, there is research ongoing. So looking at these sorts of questions, in terms of high confidence normals, and people are still conducting these sorts of analyses, and some seem to suggest that AI tools can perform at least as well. I think there's a wider, and I will come to that in the next section to a degree. There's a wider question about acceptability and substantial questions in terms of implementation, about whether this will be acceptable to the public, and therefore, in reality, practically, rather than a moral question, in terms of practicalities, AI would have to be performing substantially better than humans in order for it to be perceived as acceptable at the moment. That's certainly the impression we've got from discussions with patients and with the wider environment. I'm conscious of the time because It's now 25 to 5. So, Ben, your other question, do you want to sort of raise it?
Happy for you to pick it up as useful. I don't want to dominate here.
Absolutely. So we can get back to you on it. I can't see it in the chat for some reason, but I think that's my technical nous being shown up, I'm afraid. I'm going to move us on.
I'll mute myself.
Oh, fantastic. Thank you, Ben. Cheers. Let's move on. See? Technical nous. All right. Okay, so we're moving on to the analyses. So qualitative work that we did looking at the implementation and usage of AI tools in practice across the services that we were studying. So this was based on lots of interviews with service leads and clinicians, radiographers, radiologists, other members of clinical teams, talking about their experiences of using the tools and what they think had made a difference and what would help further. So the first point that we'd make is that the tools were being used in quite different ways. So in terms of the functions to which they were being used, who was using them, and the outcomes that were being prioritized. Also, and this was influential, the context into which these tools were being introduced, this organizational context, particularly in terms of things like service pressures, service capacity, and local leadership, varied. So to illustrate the sort of models of implementation and usage, we found that there were sort of three main dimensions on which we saw variation. So in terms of the functions to which the tool was being used, in some sites, the AI tools were only being used to provide clinical decision support. So things like flashing up heat maps showing areas of interest or concern on top of the scan. Other sites were just using the tool for prioritization of cases. So as Chris was talking about, bringing the cases that look to have abnormal features to the front of the queue for assessment, while others used a combination of these functions. In terms of users, in some sites we found that implementation had been sort of kept quite close within sort of radiology and radiographers operating within the site, whereas others it was much wider. So anyone who could access the picture archiving and communication system. So basically the IT system that lets medical images be shared within and across organizations, NHS organizations. There were also variations in which outcomes were of interest. So in some sites, there was a prioritization of cancer-related outcomes, whereas in other sites, there was a much wider interest in things like nasogastric line positioning, other lung conditions like collapsed lung, and so on. So again, there was a variation there. I guess the other important variation that we saw was that in some sites, there was very little done beyond introducing the AI tool. So it was slotted into the pathway, but not very much else happened. And as Chris noted, a number of other things were happening in some sites. So the introduction of new processes, new meetings to discuss outcomes, new roles to help patients navigate the implications of the introduction of AI. So faster turnaround or immediate referral to CT. There are also contemporary introductions of things like same-day clinics and so on, which weren't directly related to the AI, but were also seen as relevant to the performance of the system. A wide range of factors were identified as influencing the ways in which the AI tool was being used. So clinical leadership was key to engaging different frontline staff groups and ensuring that they engage with training processes and so on. Project management was key to ensuring that the AI tool was introduced in a timely fashion. So lining up all the various organizational ducks like governance permissions and integration of the tool with local IT systems. Engagement was really important in terms of reaching out to NHS staff, but also we saw a huge amount of collaboration with AI supplier teams who were central to meetings, planning, and ongoing support of developments of the tools once launched. Training was an interesting issue. So the tools were not seen as being particularly complex, but there were certain concepts. So, for example, aspects of the interface displaying the extent to which the AI tool was confident in its reading, but also things like the purpose of the AI tool. So emphasizing that this was a support rather than making the decision for the clinician. So emphasizing that this was still just a support, part of the toolkit for a clinician to make their decision. So training around those concepts was really important. And we found there were certain challenges in ensuring sufficient coverage amongst staff groups for that. Another couple of broad points were that there was a strong recognition that there was limited knowledge of AI amongst a lot of the staff groups who were meant to be using it. So there was a need for greater engagement and training around, well, what does AI do? What is it for? And what are the implications of it for my practice? And something tied to that to an extent was the feeling that there was limited national guidance on how many of these processes should take place. Just move us on. So there were a number of implications that we kind of cheated a little bit with. So some of these are partly drawn from our previous analysis as well. But we felt they were still highly relevant when people are thinking about doing this sort of thing. So the first lesson is basically start with a problem rather than the solution. When selecting an AI tool, make sure that you're choosing something that is actually addressing something that your service needs to do, rather than starting with an AI tool that can do these various things and seeing whether you can make it do something in your organization. When implementing and deploying tools, think about which elements of the process might be standardized. So thinking about things like trying to harmonize governance and safety processes and the supporting documentation so that people don't have to duplicate effort time and again to tailor it to a local organization. But at the same time, think about which aspects of implementation do have to be tailored in order to reflect local needs. So, for example, there may be particular functions that are required. There may be particular staff groups who need to be involved in an organization. We think that some of the tasks around procurement took up quite a lot of time and effort for very busy organizations, and that actually there might be value in going down more of a national procurement route, so that tools can then, so that organizations can simply focus their very limited resources on actually getting the tool into action. So rather than worrying about selection and so on, and the negotiations around procurement, actually focusing just on this is a tool that's good. How will we get it into our organization? I mentioned some of the challenges with training, and one of the suggestions we came up with was that mandatory training, and this was identified by a number of frontline and service managers that we spoke with. Mandatory training might well be quite helpful in building staff confidence in the use of the tools, but also providing assurance that the workforce is appropriately skilled to work with these tools and appropriately informed. As discussed, there's a lot of work involved in putting these tools into action. So it's really important to think about planning in the sufficient time and resources to support this. So this would involve things like dedicated project management to make sure that the processes of procurement and implementation go forward in a timely and coordinated fashion, but also freeing up sufficient time for clinical leaders, IT teams, and potentially people involved with data monitoring and management may be very supportive of getting things into action quickly. And finally, engagement is absolutely key from the beginning. So reaching out to the relevant staff groups, building links with AI suppliers, and reaching out to patients and the public were seen as really important things to support ongoing collaboration and understanding as the AI tools are implemented and sustained over time. In terms of staff and patient experiences, we found generally that staff had broadly very positive experiences of the AI tools. They enjoyed using them, they liked them, they felt that they would keep working well over time. There was a feeling that there may be particular benefits with less experienced reporters, but at the same time, sort of concerns that very inexperienced reporters should really develop their skills before using the AI tool. So there should be a degree of expertise before drawing on this as a source of clinical decision-making support. The patients we spoke with, quite a small number. So we interviewed, I think, 10 patients. Almost all of them really wanted to be told about the use of AI in their care, but hardly any of them had any awareness of this. It had not been communicated to them. Obviously, we were just speaking with patients from 3 trusts, so that's not hugely representative, but we do know, but overall, many of the organizations we worked with had decided not to communicate about the use of AI in their care. This broadly related to a recognition that this is a tool that's being piloted, and therefore there aren't substantial requirements to communicate in that way. But given that this is a sensitive topic, patients did feel strongly about it in the way that they might not about a new X-ray machine being used. Overall, patients were positive about the use of AI. This was in part because they had a general trust in the NHS. They also trusted the NHS staff who were working with the AI tools. And there was also a hope that in the cases where people might be ill, seriously ill, the AI would help identify and process these people more quickly and hopefully give them a better chance of a good outcome. But there were concerns about whether the AI tool was performing as effectively as it might. Staff noted concerns about cases where the AI tool was overcalling, so a lot of false positives around abnormal scans. Worries about, as I mentioned above, over-reliance of certain staff on the AI tool rather than using their own clinical judgment, and also questions about, who's accountable when things don't go well. Strong feeling that AI use should continue, but a desire for ongoing monitoring of performance, particularly given that these tools continue to evolve, and further evidence of the effectiveness of these tools. So kind of speaking to some of the stuff we were talking about in the Q&A earlier. In terms of the implications of the work, in terms of staff and patient experience, we think it would be worth building the evidence base around effectiveness, particularly around outcomes, and engaging stakeholders as effectively as possible around such evidence. As we note, there's not a formal requirement to inform patients and carers about the use of AI in chest diagnostics, but there is a preference, and there may be a good support for, it may be supportive of trust to share the information about AI use. And finally, patients indicated that being offered an opt-out may support their engagement with services, particularly in the event that autonomous reporting were to become an option. I'm conscious that I've gone on a little bit, so I'll pause for a second and see whether anyone would like to raise any questions. But I'm conscious that we do need to end at.
We've got a couple of great questions in the Q&A, and not all of them attributed to an individual, so I might just voice them if that's okay.
Yes.
We've got one question asking if any yellow card events were submitted to the MHRA during the ADF projects you're aware of. And if not that, perhaps I could just expand to say if there are any harms observed or near misses that came to your attention.
So we asked people about safety events, and broadly the feeling was that very little had been missed. I think the important point is that ultimately all of the decision making and so on was still being put through a human being. And so the feeling from clinicians who were using the AI tools was that sometimes the AI was picking things up that they might have missed. And sometimes they were spotting things where the AI had got it wrong. But generally, the relationship was of a second pair of eyes. To our knowledge, there weren't sort of formal reports being made to MHRA about safety incidents.
That's brilliant. And if there's time to squeeze one more in at this section, there's a question praising the candor of this evaluation, which I think we would all on the call resonate with. Thanks for sharing. And really coming to ask the question of, at the present moment, what's the honest case for continued investment in AI innovations like this in cancer diagnostics in chest, for example, given that there's sort of marginal benefit?
So I think one of the most important points that and we emphasize it in our take-home messages, I think, is that, to an extent the jury's still out in terms of certain really important measures. So with our impact and cost effectiveness analyses, we weren't able to look at some of the big contributors to cost effectiveness, such as impact on staging at diagnosis, and ultimate patient outcomes, because this was quite a rapid project conducted over a relatively short time after implementation of the tools. So we couldn't really look very much at these outcomes. So there's a big gap in knowledge that still needs to be filled. The other point, I think, is that broadly, there's a great deal of positive views from the people who are actually using the tools. They can see potential there. There's a lot of acceptability. And I think there's a need for stronger evidence on outcomes so that those can be fed into our understanding of the really big implications of these tools. But obviously with the caveat that any of these impacts are very much mediated by other aspects of how the service is implemented. So how pathways are adapted to smooth the transition of patients towards diagnosis.
If it would be okay to come in there just to follow on from Angus's response, that's all right. That question actually brings me to kind of tying together a couple of questions that I've been just responding to in the Q&A. So that question around stages of diagnoses was potentially a hypothesis kind of coming into this in terms of whether AI might facilitate an improvement or kind of more speedy reporting, which would facilitate that. I think it became, with the turnaround times as they are, and as we saw as we gathered data, as Chris kind of pointed to in his slides, the scope for such improvements as they were for turnaround times is likely to be clinically negligible in terms of kind of lung cancer patients. So we're talking hours or potentially a day or two, where I think realistically you'd probably be looking at longer periods of time for improvements in turnaround time for there to be a notable improvement in terms of overall stage of diagnosis. There may be something that would play out in terms of looking at that evidence over time, if there wasn't anything so there may still be something there, but we would need to pull long-term data to kind of be able to identify that. The other slight improvement in terms of staging of diagnosis came through in relation to, there was a question around the kind of the basis for the improvements in terms of cost savings in the economic evaluation, and they principally came from a margin improvement in terms of a reduction in the number of false negatives. So it wasn't a large shift, and that comes from a contextual point in terms of chest X-rays, in that the specificity and thus the risk of false negatives is already the risk of false negatives is already pretty low. So the negative predictive value of chest X-rays. So there is a fairly narrow window there for improvement in the context of lung cancer in any case. We did see marginal improvements in a slight reduction on aggregate across the sites we were working with, in terms of a slight but statistically significant improvement in specificity, which then fed through in terms of we modelled that patients would then subsequently represent at a later stage of cancer, or more advanced stage of cancer, having received a false negative report. So having modelled that through, obviously you have poorer prognoses and high treatment costs for those patients. So that's kind of how that played through. So it kind of, those questions just kind of helped me tie together those two inquiries. So hopefully that's been helpful.
Thanks very much, Kevin. And Angus, there are more questions we could open up to now, but I didn't know if you wanted to get to anything before the discussion section. This has been fantastic.
I'd just like to zip through the take-home messages and, really importantly, our limitations. So this is one of the first major mixed methods projects, to our knowledge, of AI tools for chest diagnostics, and taking a wide perspective on different aspects of service delivery, outcomes, and different stakeholder perspectives, drawing on local and national data sets. Some key limitations. The first one, which I should have mentioned right at the beginning, our phase 2 findings are yet to be peer reviewed. That's really important. We are going to be submitting them to academic journals in the next couple of months, well, few months. Other limitations, we were only able to conduct qualitative work in 10 NHS trusts. That limits generalizability. Real limitation, only able to interview 10 patients and they had limited diversity. So our views from patients are just an indication. We'd have liked to have observed different activities in different settings to get a better sense of how AI was being used and overseen. As discussed, we weren't really able to evaluate long-term perceived impacts, and there were important gaps in our quantitative data, for example, long-term patient outcomes. We weren't able to compare against non-AIDF controls in some of our analyses. So that limited our analysis of the contribution of the AIDF program. And as Chris and others have outlined, it was hard to unpick the impact of AI from different interventions that were going on at the same time. We also couldn't capture full data on implementation costs, and we still haven't been able to incorporate the costs associated with the medical legal claims. Key take-home messages. We think AI could support efficient delivery of chest diagnostic services, however, the reductions that we saw were quite modest and varied across services. As Kevin outlined, AI-supported services seem to be cost-effective compared to their non-AI state, but the associated health benefits were negligible. Staff and patients had a positive view of use of AI, but they wanted more evidence of AI effectiveness and ongoing monitoring, especially if autonomous AI reporting were to be introduced. AI has potential to be implemented at scale, but this relies on resources, time, and collaboration between NHS staff and AI suppliers. We need to ensure that the solutions are addressing challenges faced by services. And there's a whole range of further research required, but particularly around immediate and longer term impacts of AI on patient outcomes. We've overrun a bit. I'm just going to flash up our acknowledgements and then I can stop sharing. Also, if people want to find out more, they can use these QR codes. We can share this afterwards, can't we?
That'd be brilliant. I mean, the recording will absolutely be shared, and if you're able and willing to share slides, we can direct anybody towards that too. That'd be brilliant.
Fantastic.
Well, and thank you very much to you all for finding time this afternoon to run us through that, and also putting the questions and things sprinkled through. I think that was nice to be able to pick out things as we went along. An amazing body of work, and thanks for being able to get through it in an hour. Looking forward to the paper. I think we probably ought to bring things to a wrap there, but we'll be copying down any questions that we missed as well, so we can share those with you and keep them in mind as well for future sessions. But thank you very much. Also, just a flag for next time. Let me get the date. It's Tuesday, 19th of May. This has been a really nice, thought-provoking session to lead into the next from Nell Thornton from the Health Foundation, sharing updated findings from a survey on public perspectives around AI. And I think the autonomous use issue that you've touched on is a really live and interesting one. So thank you. And thanks very much to everybody for joining us. We look forward to getting that recording up on the website. And we look forward to seeing you along the way in the next series. Thanks very much.
Thanks again.
Thank you and goodbye.
Bye now.